Hi guys, welcome to our very first epidemiology presentation. My name is Andrea Mahoney and I am here to share with you an analysis of a random control trial that I reviewed. Since random control trials are the gold standard for determining efficacy of preventative and therapeutic measures, I wanted to choose something that I'm passionate about, which is pain management in neonates, and is actually what the focus of my DNP project is. So I chose oral sucrose as an analgesic drug for procedural pain in newborn infants. The purpose of this clinical trial was to assess whether sucrose administration reduces pain-specific brain and spinal cord activity after an acute noxious procedure is performed in a newborn infant. The study design was a double-blind, randomized control of 59 infants at the University College Hospital on the Elizabeth Garrett Anderson Obstetric Wing in London. The methods were a random assignment of 0.5 mL 24% sucrose solution or of 0.5 mL sterile water 2 minutes before undergoing a clinically required heel lance. After all inclusion and exclusion criteria were met, the findings were of 29 infants that received sucrose and 30 that received sterile water, 44 were involved in the analysis of the primary outcome measures. The nociceptive brain activity after a noxious heel lance did not differ significantly between the control and placebo groups. Similarly, the spinal nociceptive reflex had no significant difference that was recorded between the two groups. However, the behavioral analysis did alter and actually lowered significantly in the infants who received the sucrose over those who received the sterile water. There were 0 facial expressions and reduced behaviors that were recorded for these infants that received the sucrose. This means that the outcome revealed that the sucrose does not significantly affect the activity in the neonatal brain or spinal cord, but sucrose does have a clinically observable reduction in neonatal pain relief after a noxious event. The research question for this trial was clearly defined and focused. Does oral sucrose administration reduce pain-specific brain and spinal cord activity after an acute noxious procedure is performed in a newborn infant? The assignment of patients was randomized as it was a double-blind randomized trial. The allocation was concealed to all parties involved and ethics approval was obtained prior to moving forward. There were 59 infants who entered this clinical trial, 29 who received sucrose and 30 who received sterile water. Of that, 20 who received sucrose and 24 who received sterile water were included in the final analysis of the primary outcome measures after 5 infants had to be omitted for exclusion reasons. The subjects in the treatment and control groups were similar with respect to known prognostic variables in that they were all clinically stable, healthy newborns born between 37 and 43 weeks of gestation, and the study was conducted on all infants that were 8 days old or less. With respect to allocation, the infants and parents were not aware of what was being administered. However, informed consent was obtained from the parents through the ethics committee of the hospital. Throughout, only the hospital pharmacy had access to the randomization codes that were assigned. The researchers, clinicians, participants, and parents were masked the identity of the solution that was administered to each infant during the trial. There was no mention of outcome assessors or their awareness of group allocation. This clinical trial took place over a 13-month period between February of 2009 and March of 2010. The follow-up was adequate and immediate and completed. The assessment occurred during the recorded EEG and analysis occurred immediately afterwards. Selection bias was minimized for this clinical trial. As previously mentioned, all infant participants were healthy, clinically stable newborns between 37 and 43 weeks of gestation that were 8 days old or less. No infant was fed for 30 minutes prior to undergoing the clinical trial, and all were placed in the supine position and were able to self-ventilate. Those infants that were not eligible for inclusion in the study included those that had tissue damage, that had previous surgeries, that were diagnosed with intraventricular hemorrhages, or that had been born to diabetic mothers or born to opioid users, those who had been asphyxiated at birth or had congenital malformations or other genetic disorders. Infants were also excluded if they had contraindications to the administration of sucrose, if they were at high risk for developing necrotizing enterocolitis, or if they had a feeding intolerance, a tracheal fistula, or had been diagnosed with pulmonary hypertension. Additionally, information bias was minimized. The randomization and dispensing was done off-site at the hospital pharmacy. Sterile sucrose solution and sterile water were placed in 15 ml vials that could not be visually distinguished. 60 samples were randomized by block design. With respect to confounding, the pharmacy labeled them with a computer-generated randomization whose code corresponded to the identity of the solutions. There were sealed copies of the randomization chart that was stored on the neonatal unit in case of an adverse effect. There were no adverse effects reported. A major challenge in the infant population is obtaining reliable quantitative outcomes for measurement. Findings are based strictly on observation of behavior and physiological signs. The sample size was small, so the study was limited. It is recommended that this trial be repeated in a larger sample of infants. The primary outcome was pain-specific brain activity that was evoked by a one-time locked heel lance that was recorded with electroencephalography and was identified by component analysis. The secondary measures were baseline behavioral and physiological measures, observational pain scores, and spinal nociceptive reflex withdrawal activity. Surrogate endpoints were not used. The data analytic methods were appropriate for this research question and study design. The primary hypothesis was that the administration of sucrose 2 minutes before a heel lance would reduce the evoked nociceptive specific brain activity. The data analysis included a two-way nested analysis of variance that was applied to the principal component to assess the effect of the type of stimulation that was applied to the infant. With respect to the patients that were observed in this clinical trial and the similarity to the patients I care for in my practice, yes and no. I work in a level 4 NICU, so I see patients that range from 22 weeks gestation to 12 months old. Some of our infants that I care for would meet the inclusion criteria. However, it would be vastly limited as these patients are on mechanical ventilation support, and many infants I care for would have met the exclusion criteria. Many of my patients do undergo repeated invasive procedures, and that's what makes this necessary for me to evaluate. I want to find the best measure of pain management to provide the best possible outcomes for my patients. Oral sucrose is actually readily stocked and available to the RNs in our rooms, and we do so with parental advice, although it is at the RN discretion when it is used. I can personally attest to the positive effect that I have seen prior to starting an IV or doing a heel stick or any kind of invasive procedure. Just simply placing a drop on the infant's tongue does really relieve the observable pain cues that we notice. Based on this trial alone, I am not convinced that all clinically important outcomes were considered. There are other things that we can do in the healthcare field to calm the infant, including consolability, maternal closeness, either through touch or through skin-to-skin contact prior to a procedure, therapeutic touch of any loved one, or even the healthcare provider if no family is present. All of these mentioned interventions make a difference in the behavior and comfort level of the infant during any procedure. In terms of benefits being worth the cost and risk, analyzing that I think is important because I would say that sucrose is worth it, both in terms of cost and risk. The benefits of sucrose are enormous as far as behavioral comfort, and especially coupled with other interventions that I've mentioned that can be used in correlation with the administration of it. Medical interventions can be costly. They can be quite upsetting to the infant, to the parents. They can have long-term effects. They can affect organ function, kidney function, and depending on length of use, can actually cause the infant to have withdrawal effects when we stop using them. So I do think it's important and extremely relevant that we find alternate measures to providing comfort, pain relief to our neonatal population. This study was strong in that it provided data that gave us very reliable data to the insight of the pain-specific brain and spinal cord reactions that a neonate experiences when they undergo any kind of noxious acute procedure. Some of the limitations of this study include the sample size that I previously mentioned and the environmental factors that were not considered that can be used in correlation as an intervention. Additionally, some of the limitations included that it was a single center trial with a very small sample size, so the trial was not adequately dispersed. Several hospital centers should have been involved, and there should have been a larger sample set. As I said, quantifying pain in neonate is difficult. It's something that we have to just keep assessing and trying to figure out. But ultimately, the well-being of the infant is the definitive outcome measure that determines the efficacy of the medical interventions that were provided. And that's the one thing that we need to keep in mind when we're caring for this population. Thank you for taking the time to listen to my presentation. I hope you enjoyed learning about interventions for pain management in neonates as much as I did. Here are the references that I used in correlation with the analysis of the trial.